stop and go. Means very quick in interaction, and the focus is clearly on imaging guidance in complex procedure. The format is with the 3 players. There is a focus group at the cath lab in Harbin, supported also by some Chinese experts coming from different areas. And the direct interaction with the cath lab is made through the remote with experts from abroad, mainly China and APAC areas and Europe also. But then there is a third component, and the third components are you. The audience for us is very important, and we wanted to be in touch with you. So today we are going to have a nice person working with us on site directly by Jingbo Hou and Haibo Jia. The course director with me is Bob Yu. And then you have this incredible list of discussion. Of course, we have operators in the cath lab. The discussants are going to be led by Jack Tan from Singapore. And we will have people from Singapore, from Japan, from Korea, and then Hong Kong, and then Europe. 2 of the best master we have in a complex PCI guided by imaging, Facilitator and Stankovic, and then a very important Chinese expert in imaging, Dr. Guo and Dr. Song Lei and all the others. We are going to interact with them, but we wanted to interact with you. And so if you have any questions, suggestions, please go through the chat and send to us. We will try to select, and if he is interested, we will launch in terms of discussion. What about the format? Everybody, including the audience, receive one single image about the case of today that clearly, as you might see, is going to be focused on left main, ostial, and bifurcation. And we have a lot of challenges that are summed up by this sketch on the right side. And we will discuss about the challenges with our doctors and faculty. We have multiple questions we send to you. Here you have an example. And then you will receive this question. And through the chat, you vote. And you vote for understanding what is going to be. And we are took into consideration your pool. Now, without hesitation, I wanted to go back to this leader of today, that is Wei Chen. Jack Tan from Singapore is going from now to lead the entire session on this left main ostial with the diffuse disease and LAD D1 stenosis. Jack, you have the ball now.
Thanks, Dr. G. We're transiting a little bit. I want to thank Dr. G and Professor Boyi for their leadership in convening and putting together this group for this afternoon session. 大家下午好. Welcome to this session. I'm from Singapore, and it's my privilege to lead the discussion on this left main ostial lesion with diffuse disease, LAD D1 stenosis case. Just quickly on the case, later on you'll see a more detailed narration, but the patient is 60 years old, diabetes smoker with unstable angina. The cath lab, I hope the cath lab later would tell us a little bit about their strategies in these 3 main considerations. What is in their mind in terms of the most challenging consideration at pre-procedure? Is it this intermediate ostial left main lesion, the size, the diffuse disease, or the nature of the D1 LAD bifurcation stenting strategy? How do they use whether imaging or physiology to assess this case? and what to look at with imaging. And with this guidance, how to size and land stents in diffuse disease cases. And last but not least, whether this case and the discussion that of the strategy, whether it should be a provisional versus a two-stent case. So let's move on to the cath lab for Dr. Hou, Dr. Yang, and Dr. Chieh to take us through the case. Thanks, Dr. Hou. Eager to see you narrate to us the
Yes.
case.
Okay, can you hear me, Dr.
Yes,
Tan?
very clear. Yeah, please go
Okay.
ahead.
Hello, everyone. I will just introduce from the angio and the imaging examination for this patient. And please from the angio beginning. You can see from this position that the opening site of left main is about 70% stenosis. And the distal left main looks normal from the angiography. CAG. Next. And here, maybe let's maybe from the angio, the root of LAD is just near normal, and another position. And from this position, we can see that this is the real bifurcation for LAD and diagonal. The proximal diagonal is very serious stenosis. And so, because for this patient, and we have three problems. The first is for the opening site of left mean, need the stent implantation or not. If we will do stent implantation, and where to put the stent, the landing zone. The second is how to treat the bifurcation. It's just a two-stent technique. Which kind of two-stent technique? Q-lot or crush or provisional T. And so I think that for this patient is very important to do IVUS examination and to make sure about the lesion severity of the left main opening site and to make sure about how to do the bifurcation. And so now let's see the examination of IVUS from LAD to left main. Okay, can you see the IVUS?
Yes, very clearly as well. Please go ahead.
Okay, this is the distal part of LAD with some plaque. 快速走。And here 走到那个 bifurcation 那块。Okay, here is the bifurcation of LAD and the diagonal, and you can see here is the guidewire of the diagonal. But just proximal of the bifurcation, we can see a circular calcification. And so here we must do just a preparation for calcification. And then let's go to the root of LAD. 到前降支根部。You can see here is the root of LAD. But from angio, maybe we seems normal, but from the IVUS examination, we can see that has the blood burden, a big blood burden, about 60%. So maybe from the IVUS examination, and we can't put the stent at least just at the root of LAD. And now let's into the left main. And the left main still have some plaque burden, and you can see it is unstable ones. And continue moving, 就动起来。You can see the plaque burden from the distal left main and to the opening site of left main with some calcified nodule. This is the examination of the LAD to left main. Now let's see something about diagonal. Because the very serious stenosis of diagonal, and so we only by manual pullback of the diagonal IVUS examination, you can see clearly that the opening site of diagonal is very stenosis, and so maybe for this patient, and we need two stent technique about LAD and the diagonal bifurcation. So now the question is coming: how to do the left main? Can you hear me?
Yes.
Yes, please go ahead. Yeah.
Okay. So we now finish the IVUS examination for LAD left main and bifurcation. So Professor Tan, what's your opinion?
Yeah, I'm going to defer the question to someone else. Can I ask Dr. Takashi from Shenyang? You've seen the angiogram, you've seen the IVUS pullback from both the LAD and the diagonal. What is your comments and strategy?
Okay, thank you, Professor Tan, and thank you, Professor Hou. I think it's a very interesting case, and also for me, it's a very tough case because in these patients, we can see clearly both the ostium of left main and the bifurcation disease between the LAD and the diagonal. I think the most challenging lesion in these patients is the LAD and the diagonal bifurcation, because from the IVUS we can see the very severe calcification in the LAD. Also very, we can clearly see the plaque burden in the diagonal also is very big. So definitely I agree with Professor Hou, we should use two-stent strategy. And we have to keep the patient very safe during the procedure when we do the stenting in the LAD, because the ostium of the left knee is also severe. So we can also, Professor, show us the ostium of the LAD. For me, I think we still have chance to place the stent only in the LAD, not crossover, based on the IVUS funding from these patients. That's my opinion. Thank you.
Thank you very much. Very good points. Can I get Dr. Lei Song from Huai Hospital? Looking at the IVUS, do you think that you need some atractomy intervention, or will you treat the left main first or the bifurcation first?
Yeah, thank you, Jack. For my opinion, I prefer to treat the bifurcation first. I think this bifurcation is obviously a complex bifurcation. Depending on the definition standard, this side branch stent lesion is longer than 10 millimeters, and stenosis is more than 60%. And another score system is the CIT resolve score. It's based on angio. It also have just calculated are also more than 12 score, and it have a very severe stenosis not only in main branch but also in side branch, very big side branch. So I prefer to use the primary two-stent strategy for this case. And from the average today, we also confirmed that the plaque burden in both the ostium of the LAD and the diagonal is very heavy. And so I prefer to choose the two-stent strategy. And for the left man, I'm not totally agree with the Dr. Xu. I prefer to do the crossover stent from LAD to the left man ostium. I think this has to it have maybe for the just for the left man standing, it's not easy to just position the ostium not protrude too much to the left man. But if we use the crossover stent, it's much easier. That's my opinion. Thank you.
Thanks. Also very good points. Dr. Hou, I'm going to get one last opinion from Goran about this case before we come back to you. Goran.
Thank you. Thank you very much for including me first. This is a really unique opportunity to discuss worldwide approach based on imaging. I have to accept that although I'm usually in favor of stepwise provisional complexity of disease, diagonal bifurcation, diagonal LAD, really shows extensive disease in diagonal as well. So I believe that this is planned upfront two-stent strategy. For the experts from your area, I'm quite convinced it will be DK crash. You may try to do provisional tap, but I don't think that complexity of disease, extent, curve, angulation is really better choice in this case. For experienced hands, extremely tight lesion at the ostium of diagonal calcium just proximal mandates predilatation, extensive predilatation before stenting of the LAD. So I believe safest approach in this case, inexperienced hands, is DK crush. And I also support, based on the diffuse and continuous plug distribution from the LAD to the left main, I think crossover is my choice as well.
Thank you very much for those comments. We'll now move back to Dr. Hou in the cath lab. Maybe you can share with us your strategy for this case after you heard from the three panelists.
Yes. Okay, just based on the IVUS examination, I changed my strategy. At the beginning from the angio, I want to do mini crush for the bifurcation and just put the stent of LAD at the root of LAD. But after the IVUS examination, I noticed like the plaque burden from LAD to left main is continuous and with a big plaque burden at the opening site of left main. So I will first do a mini crush for the bifurcation and then just continuous stent implantation from LAD to left main to the opening site of left main into the aorta. This is my strategy. Professor Tan.
Thank you very much. That's very nice. Perhaps we can get the OCT, sorry, the IVUS operator to show us the IVUS imaging and how do you actually measure the length and the diameters for the LAD D1 diagonal. And then maybe we can get a comment from Professor Zhang Junjie on whether this deserves a two-cent strategy and what is your preferred approach.
Okay. From this, can you see the IVUS? And we just measure the LAD, and because it's a long lesion, and so we divided LAD into two stents. From the distal part of the bifurcation, we checked the distal reference, and this is about we choose the 3.0 stent. You can see here is the distal reference site. And then the length to the bifurcation is 34.42, and we choose 3.0 and 33 stent in length, and to implant it first, distal part to the bifurcation. And then second, we measure the diagonal. The reference, distal reference site is about 2.89, and so we choose 2.75 stent, and the length is 29, just 1 or 2 millimeter into the LAD, and then we use the 3.0 NC balloon implanted in LAD and to press the stent of the diagonal, and then we do choose from the LAD, the root of LAD, we measure the EL of LAD, no more than 4.0, and so we just want another 3.5 stent at the root of LAD, and then another 4.0 stent from the root of LAD to left main. This is all from the measurement of the IVUS. Professor Tan.
Can you clarify what is your measurement from the left main? The left main side?
Left main. 你看一下，不看那个这个题目。Okay, and we check the diameter of the left main. It's 4.5.
So it's a 4.5 vessel tapering down to 3.540 vessel maybe. Professor Zhang, you've seen the images and you heard Professor Hou's strategy. Is there any comments from you?
Yeah, thanks for inviting me. Actually, either from the angio and the IVUS, it's a typical complex LAD and diagonal bifurcation lesions. According to the definitive tool trial, so I think a systemic two-stent technique, I will use a DK crush for the treatment of this particular complex LAD and diagonal one bifurcation lesions. And also, I think IVUS provide a more accurate information about the stent length and also the landing zone. And particularly, actually, just before the bifurcation, I noticed the procedural LAD, there is a superficial with 270 arc of calcification lesions. So personally, I think this lesion should be with a very good pre-dilation. Another issue is about the left main standing technique. I agree Dr.'s strategy. Actually, there is extension plaque burden from the left main to the LAD. For me, I will use a one stent crossover, fully cover the ostimal left main to the proximal LAD. Another issue is about the bigger, there is a bigger discrepancy between the left main and the LAD. But I think nowadays we have very good stent platform and can be over dilate to the 5.0 stent with the 3.5 stent. Thanks for your attention.
Thanks, Professor Zhang. Very good points. There's a question from the audience. Perhaps I can get Professor Akasaka to comment. There is some note of this near concentric calcification proximal to diagonal, as well as nodular calcification in the left main. Based on what you've seen in the IVUS, does this case deserve a debulking strategy, or would you try with some form of balloon pre-dilatation? Prof. Akasaka.
Thank you, Jack. It's an important question, I think. Yes. The LAD proximal, as the previously, because of the previous comment, more than 270-degree calcium. Therefore, before putting a stent, it is very important to make a lesion preparation, I mean lesion modification. So using a cutting balloon, squaring balloon, it is important to make a fracture at the proximal LAD. And some nodular calcification I can identify by IVUS at the orifice of the left main. Yeah, but the other side is enough big, and I think we can put a stent and we can get an enough lumen diameter. But I could not check the wire bias. But if we can abrade, I try to do the abrasion a little bit. It's much better, but we can put a stent in this case, I think. Yeah.
Thanks, Prof. Akasaka. So I think we're going to move on. First, we had a poll from the audience. We asked the audience, what is the most challenging part about this case? Is it the intermediate ostial left main lesion assessment? Is it how to treat actually the left main, the huge mismatch left main to LAD segment, and which lesion should be treated first, and how to stand the D1 LAD bifurcation, or all the above? And we have a polling result here. I think all these questions are important. It looks like a lot of audience says that everything is important actually. So multiple responses are noted. So the next highest ask is how to do a bifurcation stenting properly. I think this is quite telling of what is on our minds. So in terms of technical issues in imaging in the left main, the difference or the pros and cons between OCT versus IVUS, I think most of us would prefer intravascular IVUS imaging over OCT in the ostial left main lesion like this, precisely because there are some limitation in using OCT in the ostial locations for arteries. And a small study to show that the left main is actually not all the same. I think there is a huge tapering or biconcave morphology in left main, and occasionally a combined or funnel shaped left main. So the other questions that we wanted to read from here between OCT or IVUS when you assess the left main assessment is to really accurately assess the sizing and the morphology of the disease in the left main. We can debate a little bit about that between OCT IVUS and how do you actually accurately assess either EL or lumen assessment between the two. And of course, in terms of imaging strategy, I think most of the operators here or the experts favor a more straightforward, if you see disease, do a crossover approach from the left main, and it also allows you the option of appropriately doing a port strategy. The point is well taken. Nowadays, stents are quite amenable to expansion up to the appropriate sizing, especially in the left main tapering type vessel. So I'm going to ask now, take some expert opinion from our next two experts on the imaging and how to assess from Dr. Ning first, followed by Frankie. On this case in particular, how would you gauge the use of imaging and how to assess? Is it always IVUS in this case, or would you consider OCT as well? Dr.
Okay.
Ning Guo.
Yeah, thank you, Dr. Tan. And this is a very complex bifurcation case, not only for the LED and diagonal bifurcation, and also I think even from angle Ostium circ looks okay, but still when we want to do crossover, we still need to check the Ostium circ. So I think for me, if let's say if ostium of Lefman is okay, probably OCT is more feasible for this case because we can look at the calcification. We can look at very clearly about the bifurcation, especially when we want to reveal the diagonal. So this probably OCT is better. But for this particular case, ostium of Lefman, and especially the Lefman looks andrographically looks very huge. So I think for this case, I agree to use IVUS to do the imaging access.
Thanks, Dr. Ning Guo. Frankie, do you have any difference in opinion?
Yeah, actually, I echo what Dr. Guo says. So I think IVUS will be much more versatile in this case because of a very diffuse disease, also multiple lesions from distal to LAD, and then to the a little bit ectatic left main, and then the ostial left main. But of course, OCT can still be used, but I think IVUS is more versatile. Concerning the ostial left main disease, I've experienced to use some sort of guide extension to image the ostial left main. Sometimes we succeed, but sometimes we may not, and depends on which brand of the guide extension we use. But still, because it's not always 100% accurate, so in this case, I would still opt to use IVUS to make it more versatile to see all the lesions here.
Frankie, maybe you can also let us know when you measure on IVUS, is there any preference? You always look at the EEL if you can.
So my practice, I always use EEL, but of course downsize a little bit. So usually I will go for IVUS EEL and then downsize a little bit.
Thanks, thanks, Frankie. So we're going to move on to the next question for the audience. So the next question is actually for this case with deciding treatment strategy and you are limited, is angiography actually just enough? Do I need physiology in this case rather than imaging? Or do I want imaging rather than physiology for this case? Or physiology to decide and imaging to guide? Or I'm not sure, I want to listen to the experts. So the audience have responded. And for this case where there was an osteoambiguous lesion and diffuse nature of the LAD-D1, I think most of the participants also think that imaging preference is better. So we're going to now break off and go back to the cath lab and ask Dr. Hou to show us what has happened so far. Dr. Hou, back to you at the cath lab.
And first we use just as your opinion, and we first do the bifurcation and use the 2.5 balloon and pre-dilate LAD and the diagonal. But from the IVUS exam, can you hear me?
Just wanted to see. Yeah, I wanted to see this as a main view, the angel. That's good. Please go on.
Okay. And after the 2.5 balloon pre-dilatation, we noticed from the IVUS light with the circular calcification just at the proximal bifurcation. And so we use cutting balloon, 3.0 cutting balloon, and from the LAD to the bifurcation. After that, we do the IVUS examination. From the IVUS examination, we notice that just to the bifurcation, we see that the circular calcification, just with some small fracture, but not so big. And so we then use the 3.0 NC balloon and to dilate the bifurcation for the calcification. And then the first we use 3.0 and 33 stent to the distal part of the bifurcation. And then just pre-dilate. And you can see this is the second time IVUS examination for the calcification. You can see here the arrow is the big fracture and the minimal lumen area enlarged very much. And so I think that the calcification preparation is good now. And then we choose 2.75 stent at the diagonal and the 3.0 NC balloon price the stent. And then because the EL for the LED is normal length 4.0, and so we choose 3.5 and the 33 stent at the proximal LED, just the opening side, just distal to the opening side of LED. And then after that, we revere the diagonal and with 2.0 balloon to dilate it and use 2.75 NC balloon and 3.0 NC balloon and to do the casing balloon and to dilate the distal part of the diagonal and LED stand. I use 3.5 NC balloon to dilate the proximal LED. So this is the angio after this 3. This is the IVUS examination after the 3 stent implantation along LED and the diagonal. You can see the result. And this part of the stent is very good. For the NC balloon and the post dilatation pressure is about 30 to 33. And you can see here at the bifurcation part, for the calcification bifurcation part. And this is diagonal and the LED and the shape is good. And the proximal part, this is calcification part. 到钙化的那块儿。The shape is good and the minimum lumen area is good. And so the preparation for the calcification is with a good result. And then we from IAG to left main, we make a measurement and we choose 4.0 and 21 as that to 1 or 2 millimeter into the aorta. And you can see here, we just noticed that from the IVUS examination, the opening site of the left main with calcified nodal. And so we use the 3.5 scoring balloon, 12 ATM, and to dilate, pre-dilate the opening site of left main. And then this is the position of the stent, 4.0, 21. And after the dilatation of the balloon, the position is very good. And with 4.5 from the IVUS examination, because the left main is about 4.5 diameter. So we use 4.5 NC balloon to dilate left main. And now we just finished the post dilatation. We want to do another IVUS examination to LAD and the left main. Professor Tan.
Thanks, Dr. Hou. You're already looking very, very good. I'm going to take a pause here to ask Professor Fujita. The difficulty I have always for such cases, I saw that there was 270-degree calcification, nodular calcification, and post-pre-dilatation, you had the IVUS. But I'm always a bit struggling with whether what I'm seeing on IVUS is adequate pre-dilatation. Is there any guidance from you, whether angiographically or on IVUS, whether the lesion prep is suitable before you implant stents? How do you gauge on imaging?
Yes, thank you for Jack. I think this patient have the, I think based on the unstable angina, it's always very important things. So the which part is important patient for treating. So I think left main is a calcium nodule. So it means calcium nodule is depend on the unstable angina. So in my opinion, firstly, we put the stent in the left main. I think it is safe. But in this case, luckily the four stent is okay, and expansion is okay. But IVUS shows is a very classification. My opinion is a preparation for the calculation is a need a rotablator LAD. So firstly, the put the stent left main is a safe for rotablation. So this is my opinion, but this result is very good. Thank you.
Thanks, Professor. Goran, is this what you expected based on the pre-procedure? Does this look like how you do the case as well, Goran?
I think so far is going very well, and selecting stent 4.0 I think is very good choice, because with 4.0 you are really deploying at a moderate or below the moderate pressure. You can really compress plaque at the ostium of the LAD and gives you enough structure, metallic structure inside the left main to post-dilate. I don't think I would like to see this image now, because maybe even for 5.0, according to fractal nature, could be used at the end to fully deploy stent inside the left main. I didn't see, to be honest, all the measurements so far very clearly, but from the perspective of fractal law, if you have 4.0 ostium of the LAD and large circumflex, it certainly means that that left main, according to fractal diameters, has to be 4.8, maybe 5.0. So I would like to see now image after deploying 4.0 in the left main.
Dr. Hou will show us the final imaging in the next live segment. But Goran, maybe two questions for you.
Sure.
Is there any particular advantage now with the new generation large size stents like 4550 to use those? And secondly, in the EB main, do you favor a routine kissing out into the circumflex, or is a port enough in this case?
Yeah, thank you very much. You know, to answer the first question, I think it's very easy. If imaging gives you possibility to use 4.5, 5.0, it gives you, because of the large number of a larger number of connectors and the struts, gives you more possibility to better expand stent and compress the plaque, and gives you also good radial support without stent deformation. On the other side, what was the second question? Kissing always, or in provisional? Is that the question?
Yeah, so a single stent crossover, do you just pot it, or do you favor kissing out in the circle?
So there are two aspects. There are some data coming from Korea showing that pot may be sufficient, but in European Bifurcation Club perspective and in our consensus documents, if you are using image guidance and you visualize clearly strut jailing the ostium of the circ, we recommend to routinely do kissing and remove that metal from the ostium of the circ. In this case, there is a large circumflex, and in my practice, I think even if it's crossover, kissing has advantages over pot, because by kissing, what you achieve is by simultaneous inflation of two balloons, you position carina in the center as well. So kissing gives you better expansion in the polygon of confluence and distal part of the left main. And on the other side, you have carina in the center. If you do pot side pot, you don't achieve carina in the center. It's always pushed back towards the circle.
Thanks, Goran. Again, very good points from you. I'm going to just move back a little bit to some pointers where to land and not to land your stents. So I think classically, whatever you see on IVUS or OCT, you try to avoid abnormal segment, whether it's a plaque burden of more than 50% or lipid-rich plaque to reduce the event rates. Sometimes in a very diffuse lesion, you just have to pick the closest normal segments. And I think the advantage of any form of imaging, like what Goran says, is that it gives you really the confidence to size the stents accurately and the opportunity then to use appropriately large size stents. When you don't have intravascular imaging, I think sometimes it's quite fearful to use appropriate 5.0 and above stents. So I think a practical tip one, longitudinal extension or lipid core in the left main is pretty common. Like in this case, angiography, it looks fine, but the ostial LD is definitely involved. And tip two, decide the landing zones and the stent size accurately based on your measurements. Typically, EEL will give you a good estimation of true vessel size. So we'll call upon our next three panelists to give their opinion based on imaging. Any other tips about decision-making in bifurcation or left main PCI? We'll start with Professor Kim, and then Professor Akasaka and Dr. Yu Chao. Thank you very much. Professor Kim?
Yeah, can you hear me?
Yep,
I think it's a very important point because we avoid the lipid-rich plaque to reduce the periprocedural MI. Also, the other important point, I think more than 50% plaque burden, which is usually associated with during future stent restenosis. So I think this is a quite important point. Also, the other thing is that in the IVUS measurement is somewhat different between IVUS and OCT. IVUS usually recommend the mid-wall, media to media measurement, but OCT, we can do both EEL, sometimes lumen diameter, but especially we use lumen diameter, usually up rounding to the stent side to the nearest 0.25 millimeter in opinion study, but when we use EEL, down rounding the stent diameter to the nearest 0.24 millimeter in lumen. But I think it's somewhat difficult to measure decide the accurate size in left main because LAD and proximal LAD and left main is somewhat a huge difference, size difference. So I think in this case, we can use some mean reference diameter sometimes. Then we can, at first, we dilate with nominal pressure or subnominal pressure, and then we dilate more in the proximal part.
Thanks, Professor Kim. Also, there's a question in the audience about if you do kissing balloon inflation at the LED-D1, how do you choose the size of the kissing balloon and the pressures? And Goran made a comment that you use a NC balloon size according to the distal reference diameter of both feeding branches. So the diagonal branch and the LED distal reference for the kissing size, and then the port for the proximal. Can I ask Professor Akasaka whether, is there any situation you use a compliant balloon instead? Based on your intravascular imaging findings, is there any situation you use a compliant rather than non-compliant balloon?
At the time of kissing balloon, I think the main branch we often use a non-compliant balloon, but sometimes the side branch we use a non-compliant and compliant balloon because we can just control the size depend on the pressure, right? Therefore, it's depend on the situation. So in this case, I think diagonal should be 2.5. LED also the 2.5. Kissing might be enough to dilate the proximal. I think based on the imaging, because LED proximal is a little bit bigger, right? But we can control the pressure, right? So the kissing is important to get enough lumen at the side branch orifice, right? Therefore, we can control by pressure, right? At that time, non-compliant, compliant balloon is okay, yes. And also the imaging, I think in this case, it's quite tough case, I think, because as someone said previously, proximal LED, I like to use an OCT, but and the orifice we miss to measure by OCT sometimes. But if we use child catheter like an guideline or guideline, we can see the orifice through the catheter sometimes. So initially, if we can use an IVUS and OCT to imaging device, we prefer to use an OCT first, and then if we miss to measure the left main orifice, we try to use an IVUS to check. Yes, but this is actually the tough case, and if we can use only one imaging device, IVUS is better compared with an OCT. But the importance of OCT is, as you know very well, we can measure the thickness of the calcium. Therefore, to treat the proximal LAD, if we know the thickness of calcium, it might be better to treat, right? And also the thickness of the calcified nodule at the left main orifice, much more good information we can obtain, right?
Thanks, Prof. Takashi. I think you answered Dr. G's question, whether there's any role of OCT in this case, whether post stent assessment. I think you outlined the pros and cons of OCT in this case. Dr. Yu Chao, do you have any further tips and tricks for this case regarding imaging?
I think if we want to do the process PCI, we need the intravascular images. And according to the IVUS image results, we can find the calcium. We know there's a calcium about the plaque burden, and to select the to deal with the bifurcation lesions. So I found the strategy 2 stent or 1 stent. I think the IVUS give us a lot of the information about the plaque, about how to make the strategy to deal with that. I agree with Dr. King, and if there's a diffuse lesions, we cannot put the stent, the landing zone, the stent landing zone is not the normal segment. We have to select the right landing zone. It's not don't select the lipid core or very calcium calcification part of that. We can avoid a lot of the trap. I think we need the intravascular imaging.
Thanks, Dr. Yu Chao. I think the points are all very well taken. I think the take-home message for me is that for such cases, any form of intravascular imaging would be nice to have. And I think quite essential to get optimal results. The pros and cons of IVUS versus OCT is quite well illustrated. OCT does give you better clarity resolution. You can measure better the calcium thickness as well as arc. And the great clarity and ease of use is there. The downside, of course, is the need for normal renal function because you may use a bit more contrast. And of course, if the disease is so diffuse and subocclusive, sometimes you do need to pre-dilate before you can get a good image. And also the limitation is very large size left main occasionally. And in this case, the ostial location doesn't make it more difficult, although there are tips and tricks to the OCT in such a situation. So we're going to go back to the cath lab. Dr. Hou is now going to show us how to assess the final result on imaging.
We just finished our work, and so you can see from the after the stent implantation and the post dilatation with 4.5 NC balloon, and we first examined the left main with the IVUS， 放倒数第二个。And you can see that the stent malposition is good. Position is good and the expansion is good, but just the opening side of the left main, the shape is irregular. 到那个开口那边。You can see here the shape is irregular and with the longer one diameter and the shorter one, and so we second use the 4.5 balloon with high pressure, and the pressure is aimed to 25 ATM, and then we do OCT IVUS examination again. 最后一个，不，倒数第二个就是。明白，那个这倒数第三个。对，一开始这个 我要看做好的那个 OK， the technician and don't know my meaning, and after the dilatation with the 4.5 high pressure, and you can see that the opening site of left main is now become better, and so we do the examination to the diagonal. This is the diagonal stent, and you can see some under expansion. 你往前能快速走。Under expansion, but we just post dilate the diagonal with the 23 ATM. And so I think that the opening site of the diagonal is about near 4.5 square millimeter. I think that this is a better result, and so I don't want to do more work along LED diagonal or left main. And so you can see from the angio, this is the final result for this patient. From this position, you can see the opening site of left main and the proximal LED and the middle LED is very good. Do you think so?
Thanks, Dr. Hou. I'm going to defer the opinion to Dr. Qian from Huai Hospital. Dr. Chieh, what do you look out for your cases at the end of the procedure? Is this acceptable?
Thank you for inviting me to join this wonderful meeting. And to me, to assess, actually, we can measure three parts, right? One is the diagonal, one is the LED, one is the left main. So can we use the absolute MSA or relative the ratio? And so for this kind of long diffuse lesion, actually, maybe we should accurately know to measurement the minimal stent area distal to the diagonal part and the proximal LED and the left main and diagonal part and separately to assess the final result. But because we don't have the accurate number, maybe later Dr. Hou can give us the accurate number. But it looks the IVUS the pullback looks fine, looks fine. And actually, sometimes the difficulty is the orifice of the diagonal orifice. How to achieve the this part because this is the most resources part. So how to actually I have question, and for this very big diagonal, which is the criteria for the orifice of the diagonal and the bifurcation part, the minimum stent area.
So Dr. Hou, the question is, what is the minimum MLA you hope to find in these vessels at the bifurcation?
Yes, I just think that because for this patient, you can see the bifurcation shape is very good, but the opening site of the diagonal, the area is 4.5. I think that for such kind of diagonal, maybe more than 4.4 square millimeter is enough. And I don't want to do FFR for this patient because it's a complicated PCI treatment for this patient. Okay. And we really measure the LED minimal lumen area and the left main. You can see the result. 要看做前降支的最小管腔面积。就是看最后一个，就是前降支根部，测一下。And this is the proximal LED. And you can see that the area is more than 11 square millimeter. 看坐着干。for left main and the minimal lumen area here, you can see the area is very big. The value is more than 12 square millimeter. So I think that for this patient, the minimal lumen area for LED left main and diagonal is enough. So this is my opinion, Professor Tan.
Thanks a lot, Dr. Lim and Haan. Do you have any comments or tips about the final imaging What's the danger of trying to be too perfect? Yeah.
Yes. Okay. First of all, thank you for having me here, and I must congratulate Professor Hou for an excellent demonstration. Left main intervention is one of the most challenging conditions that we can encounter in interventional practice. So you did a really good job here in this complex case. And I think for me, when I assess left main intervention, using IVUS to optimize, I would look at the stent expansion and stent apposition. For stent expansion and apposition, usually the MSA at the ostium is very important. I would at least go for more than 90% in the left main, in the ostium. And the stent apposition is important as well. The plug burden has to be less than 40%. And in this case, I can see that the area, the MSA, in this case, I could see that the MSA achieved is large, is more than 11 in the left main and in the LAD, and then even bigger in the left main, as I can see. So stent expansion is adequate. Second is the stent there is complete apposition of the stent in the lesion. As seen in your IVUS pullbacks, there was no dissection and hematoma. So just now, Jack's question was, when do we stop? In very calcified left main, sometimes we do not want to go for very high pressures of expansion, because you can actually cause a dissection. You can actually cause perforation. Yeah, but you have done a great case here, and I think the results are really good. In this strategy, I agree. Provisional stenting, no side branch dilatation, no side branch kissing dilatation, and the results look perfect. Thank you.
Thanks, Haan. I'm just going to go and take an audience poll again. So in left main ostial lesions, what's the most challenging result post-procedure? Is it when there's a lot of stent protrusion into the aorta? Is it a left main stent malapposition? Is it a stent under expansion and bifurcation, like what Dr. Chieh mentioned? Or is it occlusion of the side branch, or the rate of occurrence, predictor of the rate of occurrence? So the audience think that their most fearful complication is really a side branch occlusion, and the stent expansion at D1 bifurcation site that was brought up. Of course, under expansion is then predicted to the rate of recurrence of ISR, particularly at those areas where it was heavily calcified. So I think Professor Zhang Junjie have this study which shows the ultimate trial that shows really optimal PCI that is intravascular imaging guided, does improve outcomes manifold, and it does help you land your stents in areas where it doesn't get into trouble, showing effect in long-term or mid-term results up to 3 years. So in terms of IVUS optimization, I think what we're aiming for is MSA less than 90% of at least the distal left main reference lumen. But you do have to take note, based on what was narrated earlier, the type of shape of left main that you have, whether it's tapered down, whether it's biconcave, whether it's a reverse funnel. But you really want to achieve MSA at least in those tapered or funnel left main of at least 80% and 90% for both the rest. A word of caution then is those nodular calcification, heavy calcification. Sometimes too perfect a result can get into trouble, so you have to gauge each case by itself. So now we're going to have some last result comments by Professor Zhang. You can comment on your ultimate study as well as your definition 2 trials on anything here, as well as Professor Torre for this case. Thanks, Professor Zhang.
Thanks, Dr. Chan. Thanks for your invitation. So actually, according to the ultimate trial, we only have 51% of patients and 60% lesions we got optimal IVUS guided PCI result. So Actually, for suboptimal, which was associated with a high rate of TVF at either 1 year follow-up and 3 year follow-up. So accordingly, we should achieve the optimal IVUS result. However, like this particular case, Dr. Juice, actually they could do an excellent job, except for the ostial diagonal. Actually, it's a 2.75 stent, and the minimal stent area at the ostial diagonal only 4.5. Actually, I think it's a suboptimal result. In terms of stent expansion, only 0.8. However, actually, doctor have tried her best to do the post dilation with a high pressure. I fully understand his feelings. Actually, I think the main reason is this is a very eccentric plaque at the ostial diagonal and also with very rigid lesions. Personally, for this particular case, I think maybe before we put a stent, we can use a scoring balloon or cutting balloon to a good lesion prepare. Then we can get an optimal result after we put a stent in the post dilations. Thanks for your attention.
Thanks, Dr. Zhang. Again, very, very strong comments. Dr. Torre, maybe I can ask you then, what were the steps you think, especially the question I had initially in between pre-dilatation, to gauge whether your scoring balloon or your high pressure balloon was enough before you implant the stent? Because if it's not enough, you tend to end up with such result where the MLA may not be, or the MSA may not be optimized. Professor Torre?
Yeah, I think that it's quite definitely important to when you are doing a procedure to have a clear idea what are going to be your targets. The targets, I mean, what is the minimal stent area threshold you are pursuing. Yesterday, in the case we showed yesterday with a lot of calcification and diffuse disease, we saw that the preparation of the plaque is definitely important in order to get a proper expansion of the stent. Then, before any stent is implanted, you have to be sure that the pre-dilatation loom, the expansion of the balloon you are using in the pre-dilatation is the same you are going to target with the stent. Otherwise, you need more preparation of the plaque. Second, when you are checking the results of an stenting with imaging, you need to follow a rule of thumb. No? First, distal edge, procedural plaque, dissection, hematoma, body of the stent, minimum stent area, expansion, proximal edge, malapposition, or deformation. In the case of the ostial, it's very important first to see the distal landing site if there is no dissection or residual plaque. Second, you have to see the expansion of the stent at the ostial level. Please be careful because sometimes ostial lesions are not only because plaque accumulation, but also constitutive remodeling, negative remodeling, particularly in women. Then in this case, if you are very aggressive with expansion, you can just simply perforate the left main, which is a disaster. Then please check EL in the ostium because sometimes it's smaller. It's a funnel shape. That's why in our peritoneal intervention, I recommended not to be very ambitious in the expansion of the ostium when the vessel, the EL, is smaller because it's a funnel shape and you have to respect the anatomy of the left main. And the very last important point is proximal stent edge because you are in the aura and you can deformate the stent with the guiding catheter. The last thing you have to do when you are examining ostial stent is to check the proximal stent edge and to check that it's not deformed, it's not distorted. And maybe you have to finish with an IVUS examination with the catheter disengaged of the stent and to check this because sometimes the stent is like crushed. Then is this my rule of thumb, my step-by-step imaging checking of the optimization of the stenting.
Excellent points, Dr. I really like those comments. Before we move back to Dr. Hou, whatever that was presented, I thought there was an excellent result at the cath lab. I'd like to give Dr. G 5 minutes to show us a little bit about what's in store in terms of imaging guidance and the latest to come for OCT. So Dr. G, maybe you'd like to share with us how imaging can be much faster and automated in the future.
So thank you very much. Can you see my screen?
Yes, clearly. Dr. G, please go ahead.
Okay, everybody was talking about how much is important to optimize the stent result. We saw today the mixing about the strategy, the measurements, what was remaining suboptimal at the level of some calcification. We spoke about the lesion preparation at the ostium, the nodular calcification. Calcium is going to be at the center stage. This is live and from remote. We are going to watch now the new AI supported software from OCT to get more automatically done identification of the calcium, display, and measurement. This is one section. The calcium is in yellow. The numbers are on the right side about the angle, the thickness, automatically done. You can see that the calcium is going to be projected directly into the angel. So you will know exactly the position of the calcium. And one of the points is, well, if we are changing zone, how it looks like. So I'm clicking, I'm going to a different segment with the calcium, and you have a different number. So you have automatically display the lumen. You have a section by section identify the content of calcification and display on it. And if you're going outside of the most important calcified region, you can see different numbers in terms of total angle. That now is much lower in terms of thickness, with the arrow identify what is going on in terms of thickness. Where is the point where you have the thickest part of this calcification? Then you have some new coming information. And this new coming information, forget the story of the right side, the left side, the distal proximal, because in this new software, you needed to have an inversion. On the left side, you have the proximal part of your vessel, and on the right side, you have the distal. But the most important is beside the content, the morphology, beside the automatic lumen detection, you start to see these white lines. What are the white lines? Is the automatic detection of the EEL. And the people might say that, hey, Giulio, what does it mean automatic detection of EEL? Can you show to us some example? Here you can move and see where in the center we have automatic detection of EEL. We are going to the same frame, and you can see clearly depicted the EL in this part. And it's not present when you have this type of calcification. When you have a calcification and damping of the signal, also with the lipid, you cannot detect the EL. And if you don't have the EL at the proximal part, it's not going to display any EL, it's going to display the lumen. In addition, you might review something about comparing different cross-section and pullbacks. And when you compare different pullbacks, you have immediately what you had at the beginning in terms of a display, in terms of minimum luminal diameter and area. And then you know about your results, and you know about the extension. And you can use different type of criteria. You can arrange for dual or tethering, and then you have a different type of display showing the optimal results. This is what is coming soon. Somewhere is already available as an essential contribution of AE for dealing with calcification.
Thanks, Dr. G. Are you able to stop share?
Okay, let me see how to get out. 1 second only. And stop sharing screen and going back to you.
Yeah, thank you very much. I think I just have an announcement to make before I thank everyone. The hour fly away really very fast. So subsequently, there would be a hands-on session on the acquired images so that participants who are keen can go on to the live streaming review by the team at Harbin Medical University by Dr. Haibo and Chao Yun to look at the case and study in more depth and learn from the experts. We want to really then go back to the cath lab to sum up and give our parting words from the team by Professor Hou and close sessions on our behalf. I'd like to thank my team of panelists and really a lot of hard work by the Harbin Medical University second affiliated hospital staff for putting together this stop and go sessions and teaching us a lot through this interactive learning session. And much appreciated to the team at cath lab, Professor G and Professor Boyi for leading this effort. Dr. Hou, please.
Okay, thank you so much, Professor Tan. Yeah, I'm now, our team is in the meeting room. We just finished work and back to the meeting room. I think that for today, for this patient, the IVUS examination really changing our treating strategy in a great deal. And you know, like from the beginning, from the angio, I want to do just to put the stent at the root of ILAD and to treat the bifurcation, maybe a short stent just along the ultra left main. But after the IVUS examination, and we noticed like the first from the angio, the calcification it is not so serious, but from the IVUS examination near the bifurcation, the calcification is very serious. The circular calcification, we must do the better preparation for calcification for this patient. The second, the opening site of the left main also have the calcified nodule, and so we use the cutting balloon, scoring balloon, and the NC balloon, and to prepare the calcification to get a better stent expansion. And the second, for this patient, because the plaque burden at the root of ILAD and the plaque burden of the left main is continuous and the big plaque burden, and so we changed the strategy from just a separate stent implantation to ILAD and the left main for continuous stent implantation, and use IVUS to exactly to measure the EL for ILAD and EL for left main, and so just to not to make the perforation for ILAD. I think that for imaging examination just for this patient, IVUS examination is really do a great deal work and get the better result for this patient. Thank you, Professor Tan.
Thanks, Dr. Hou. I think you summarized it excellently. I think in this case, the main learning point for me was that imaging in this case, like in a lot of published study, did change your strategy and practice, and you had a wonderful result. So congratulations to the team. I'd like to again finally thank the audience for spending Saturday with us, and do keep safe and well, everyone. And I hope to see everyone very, very soon. Goodbye and thank you.
Bye-bye. Shall we go back to the cath lab 1 second?
Bye-bye. Yeah, sorry, Dr. G. You want
Shall we
go
go back to the cath lab 1 second? To the Harbin group 1 second? To stop
yes.
sharing and we can have the group of Harbin.
Yes, all the staff and the team is now here in meeting room, including Dr. Yang Guang and the technician Yu Huai, and all the staff and work prepared the case and working in our cath lab. And thank you so much for your 2 days and 3 hours in hybrid live course on imaging guidance in complex lesion. I think that because these two cases. And the first day is about a serious calcification by OCT guidance. And we know that we must prepare the calcification to get the good result. And today is just the left main and the bifurcation by IVUS examination and really changed the treating strategy, and this leading to the better result of the patient. I think that this is very important for the patient's prognosis. And thank you so much for so many expert cardiologists just from ACAP and Europe and China coming here and from internet and to the deep discussion and communication, and especially thanks to Professor Guagliumi and Dr. Jia Haibo's efforts in organizing and implementing this activity. And I look forward next time and to communicate with all experts again. Thank you so much.
So the message for the future is we wanted to have you back physically for the next meeting. It was a tough time for everybody, everywhere in the world. It was a fantastic journey in these 2 days. Thank you very much to all Chinese colleagues that work hardly inside Harbin, outside Harbin, making comments. And thank you to everybody from the APEC countries, and especially today, Jack Tan. He was terrific in dealing this interaction with all our friends. Thank you very much also to the Harbin group and Dr. Hu, and outstanding performance, and see you soon in Harbin or everywhere in the world. Thank you very much. Take care about your time.
Okay.
Ciao.
Welcome
Bye-bye.
all professors
Bye.
coming to
Thank you.
Harbin.
再见，拜拜。
Bye.
Bye bye.